Well, good day. Thanks for letting us present our group's work. Lucy Savitz and I had a pleasure of leading a very lively and engaged group. And thanks to Maria and Neil for helping with the notes that bring us to this morning. So we started talking about workplace CPD just with a case that was only important just to really seed the conversation in the group. But the case we presented discussed 5 VA, U.S. Department of Veterans Affairs medical facilities that were participating in a national demonstration project in primary care education to establish a collaborative work group across those 5 sites to prepare interprofessional clinical faculty and staff to teach performance improvement to interprofessional trainees at their sites. And the instructional design was expert-led conference calls followed by expert and collaborative peer coaching as the participants engaged in actually developing improvement strategies on the topic of low acuity use of emergency department for impaneled primary care patients. So the case was complicated and presented kind of purposefully complicated to represent a number of real-world workplace situations. It was a multi-site project, it's an interprofessional project, and it was extensively workplace learning based in the instructional design. So going through the outline of the stakeholders for this, we thought it might be worth pointing out that patients probably are the primary stakeholders for performance improvement, directly or indirectly. The institution, the clinical institution itself is stakeholders, but clinical institutions are complicated and have different levels of not of interest, but folks at different levels of the organization may have different interests in what goes on, and so we're thinking of just distinguishing between senior management and mid-management as stakeholders of this. Of course, the frontline clinicians and frontline staff. Because this example included academic goals, the academic affiliates, in some cases who are sponsors of the programs where the trainees were engaged, were stakeholders to the processes because they were receiving some funding for this, not from the clinical facility in which this was occurring, but from our central office function. Our office at the Office of Academic Affiliations at VA Central Office was a stakeholder. And although not in this case, but in other cases, there may be community representation that would be important stakeholders in types of interventions, and certainly in specific examples, many of you may be able to think of other stakeholders for a specific engagement. In looking at options for that section of the business plan, we wanted to start to recognize that there's options about even what problem you want to take on. What is the opportunity for improvement that is more important than other opportunities to choose? We wanted to review that even when you've chosen something to improve, you've got choices about what extent of results you want to accomplish. Are you looking only for a short-term result? Are you looking for a long-term result? Is it important to just measure some kind of process performance or output, or are you looking for more substantial outcomes? And of course, depending on those decisions, you've got choices about your instructional design to accomplish those. And you've got to choose how you're going to measure what it is you're trying to do. Lucy wanted particularly to talk about the decisions of your unit or units of analysis in this, and that should be really done prospectively. There are so many moving parts in workplace, just in the process of clinical care and then bringing in educational activities that interact with those, that you have to be as deliberate as you can. that you want to measure what matters, and what usually matters involves patients. And there's a whole variety of outcome measures that involve clinical outcomes, okay, and team knowledge and other educational, knowledge, skill, ability, educational outcomes. So we got to the cost-benefit question, and really, after we talked about it a little while, we crystallized a concept that I hadn't really recognized before that conversation, which was, given that we know that there's this interaction between the clinical environment and the learning environment, when we're looking at workplace-based educational interventions, we've got to think about those as separate but related elements. And we made a number of lists of bullets of different types of costs and benefits. And it seemed, in reflection on the list we made, that we might be able to think about this more in a tabular way to try to clarify what these differences are, and that we can think of the education intervention relating to the clinical intervention but still being different, that the development costs, for instance, of the educational activity or the faculty time for curriculum development and the instructional design, and hopefully there's data that are part of the educational intervention, and you're going through the outcome and evaluation planning. The clinical side of the intervention, if you're teaching people to do PI, the PI intervention itself has its own staff time to develop, and the clinicians need to work to develop their aim statements and assess the current state of the clinical issue that's being improved. It has its own data management needs and the need to identify the clinical outcomes. Then similarly, once the activities begin, there's operational events, and the operational activities for the educational component of the intervention may be discrete from the operational events of the clinical component. So the faculty time for the education side of it is different than the opportunity time for the clinical staff, both who are as champions and participating in all the clinical staff working in the actual clinical processes that are getting changed. And one observation to make, as I'm going over time and getting the stink eye, is that these processes may not operate in parallel. The education development may occur, proceed to the education operation, which then initiates the clinical development, right? You've got to figure out what's the right sequence for each of those. The last comment would just be to comment on risks, which we didn't talk about a lot yesterday, but the risks of any performance improvement issue itself are just whether you're shifting costs from one place to another. Are you really saving money? The substitution risk, that what the thing you're choosing to do is distracting people from doing other things that are important and add value. The potential liability if a new process has undesirable outcomes. And some important cultural issues, which is that any unsuccessful educational engagement or clinical engagement that fails generates cynicism, which is a sea anchor for future improvement. And the risk that some interventions you develop may be at odds with other performance improvement goals. The example Lucy gave when we were talking about this was, to improve certain ICU infections, they may have a bundle that leads to automatic antibiotic use, which may contradict an antibiotic stewardship goal of a different change package. So that's what we got. So thank you very much, and thanks to the group for helping us
Thank you,
think about all
Stuart.
that.
Sylvia.